Good morning.
Good morning.
And again, good morning.
Good morning.
Thank you for all those who couldn't muster up a good morning. There's coffee over in that corner right there. My name is Dr. Joan Reed. I'm Dean for Diversity and Community Partnership at Harvard Medical School. We have a lot of other titles because Harvard gives you titles, but the most important one for today is that I'm director of the Commonwealth Fund Fellowship in Minority Health Policy and also the Joseph L. Henry Oral Health Fellowship in Minority Health Policy. And so pleased to welcome you from across many of our Harvard institutions, as well as colleagues, friends, family, and others from across the country. Many of our Commonwealth Fund Fellowship alumni and alums from our other programs are also here with us today, as well as representatives from the Posen Commonwealth Fellowship. And thank you for joining us, both here in person and online. Each year at this meeting, health professionals, students, residents, staff, individuals from community agencies, and others are able to hear about, learn about, and better understand healthcare and health equity issues that impact our nation's most marginalized and vulnerable populations. This morning, we'll hear from Commonwealth Fund Fellows, HMS Faculty Fellows, and a Dean's Postdoctoral Fellow as they present their research and practicum findings. And in a minute, I'll tell you a little bit more about them. I also want to thank Dr. Laurie Zephyrin from the Commonwealth Fund for participating as a commentator in these presentations. The Commonwealth Fund in 1996 supported the establishment of the Commonwealth Fund Fellowship in Minority Health Policy. And as there's fellows from different cohorts, you come from different names of the program, but you're all Commonwealth Fund Fellows. That's how we talk about it. And it's designed to prepare physicians, particularly physicians from groups underrepresented in medicine, to become leaders who improve the health of marginalized populations by transforming healthcare systems and promoting innovation in policies, practices, and programs that address issues of health equity and social justice and the determinants of health. The Joseph L. Henry Oral Health Fellowship in Minority Health Policy was established in 2005 for a similar purpose for dentists. With this May's graduation, we will have trained 164 physicians, dentists, and mental health providers. It is an honor to be a part of these fellows and to watch the amazing things that they're doing. Before we begin, I want to share a statement of mutual respect and public discourse from the medical school. And basically, as I read this, part of what it says to me is to do what my grandmother told me to do and be respectful and be kind and to listen and to not assume and to be open-minded so that we can learn. And now for a few housekeeping items. All lines will be muted and the chat is not available. Live closed captioning is available and you can turn that on for those who are on the web. And your questions for those online could be submitted to the Q&A function. And at the end, those who are watching this presentation online will have poll questions to answer. And a recording of today's program will also be available on our website. And now for an introduction of the two fellows who will be presenting today. Nana Afua is is Commonwealth Fund Fellow in Minority Health Policy, founder and Chief Medical and Innovation Officer at Shared Harvest Foundation in Los Angeles, where Shared Harvest Foundation's mission is to spread compassion through wellness, service, and relief. In her role, she served as a clinical instructor and emergency medicine physician with a focus on health equity. Dr. Afua is committed to measuring the impact of minority clinical pathway programs, as well as medical workforce wellness and retention models. And our second presenter is Dr. Jodian Pinkney, who is currently an attending infectious disease physician at Massachusetts General Hospital, and she aspires to be an expert in the field of infectious disease-related preventative healthcare for reproductive age Black women domestically and in the Caribbean. And with that, I welcome Nana to the podium.
Thank you. Oh. Wrong one, you're on the right one. Yeah. Good morning, everyone. Learning from my mentor. Good morning, everyone. As you heard, my name is Dr. Nana Fominin. It is a pleasure to be here. I took this year off sabbatical. I think we're not. There we go. Perfect. So I took this year off sabbatical to really explore a topic that's near and dear to me. Make sure I get this. And it's the topic of burnout. Dr. Benecourt, many of you know, he's the president of the Commonwealth Fund, said very eloquently, burnout, demoralization, and administrative harm are a clear and present danger to the future of healthcare, and we ignore them at our own peril. So burnout is a major public health crisis that we have seen, and it's an institutional problem. The Surgeon General reported that in the next 4 years, we will see a decline in the healthcare workforce by 34%. 81% of the healthcare workers are looking for a workplace that supports mental health, and this sentiment is true globally. In my work at Shared Harvest, our focus was on wellness service and student loan relief, and that's because of the young physicians that we worked with in the pipeline who are feeling mentally and financially exhausted, exacerbated by alarming amounts of medical education debt. 81% of our US minority physicians borrow to pay for their medical education compared to 71% of the general student body. And in our program, we actually work with 300 physician volunteers through Shared Harvest. And during that pandemic is where I actually had the opportunity to speak anecdotally to people who are really struggling in this. And women of color are carrying the majority of that minority student debt burden. The graph you see here to your left, my right, your left, is really looking across ethnic and racial disparity, ethnic and racial breakdown of the average student debt. Clearly, we're looking at $180,000 to $200,000 in student debt. And this growth rate is about 14%. So this was in 2018. So aim of my research is to investigate post-pandemic associations between burnout, medical student debt, and financial well-being. A lot of the burnout definitions are typical, but what we're seeing and what the Commonwealth Fund report showed in 2022 is across high-income countries, burnout rates are increasing and the definition of burnout is changing. The top 3 issues we saw were in this study was that physicians retiring are retiring earlier. Greater than 55 years of age are going to be retiring the next 3 years. As in the same note, increased burnout among younger physicians, expressing stress and emotional distress. And those physicians are also sharing that they're seeing a decline in the quality of care they're able to give to their patients. Physicians of color are expressing issues of structural racism, demoralization, and failure to really address root causes. In this study that was done actually here, there was a 15 peer review articles, cross-sectional studies that looked at the differences in the definition of burnout. And the reason why I added this was not so much the results of the studies to show there was a difference, but that the measuring tool that we were using were inadequate. So before we start getting into the meat of my practicum, I wanted to just highlight some of these important terms that you're going to see. Physicians for a Healthy California is the wonderful community partner that I was able to be a part of. They launched the Cal Health Care's loan repayment program. And Medi-Cal, for those of you who are not from California, is Medicaid in California. It's the health coverage for low-income individuals and families. Health professional shortage areas are also known as medically underserved or workforce shortage areas. And of the loan repayment programs that exist nationally, the most common ones are the Natural Health Service Corps and the Public Service Loan Forgiveness Program. So now a little bit about Physicians for a Healthy California. They were launched in 1963. They're very innovative. They launched their loan repayment program in just 9 months. Their mission is to cultivate, recruit, and retain, and they have programming for each of those aims. Of their program, they average about 300 awardees per year. They give $60,000, which is higher than the national average, with a total loan repayment of about $300,000. Their endowment is $340 million, usually taking out of tobacco tax tax funding in California. And their total cumulative loan payout so far has been $72 million. But what is really important to know and underscore here is that they increased the Medi-Cal caseload that they're able to see. So 69% compared to the state average, and they increased the number of specialty care service by 80%, which is remarkable. So in my research, we wanted to conduct a survey to explore these themes related to burnout, medical student debt, and financial insecurity. We wanted to conduct that systematic review of other LRP programs to Cal Healthcare's, and then design a comprehensive measuring tool that measures financial well-being and burnout for providers with medical student debt. These are some of the key advisors that were instrumental in keeping me rooted in the work I was doing and honest. And so in phase 1, we looked at 17 survey questions. 14 of them were actually taken from the Stanford University Professional Fulfillment Index and the Maslow Burnout Inventory. And then we curated 3 of our unique own to really target financial well-being. All the questions were spread through SurveyMonkey, through social and professional channels, and we had 5 groups respond. We looked at qualitative analysis of themes, quoting those themes to uncover perspective and experiences. Some of the common groups that represented was Reed Scholars, thank you, Shared Harvest Volunteer Network, California Black Health Network, and alumni from Student National Medical Association, and residents across the University of California medical institutions. So these were the 17 questions that we derived. 1 through 9 were demographic data. Questions 10, 11, 14 were the ones specific to loan forgiveness or to the study that we're looking at. How do you define financial security? What does burnout mean to you? And what does equitable loan forgiveness program look like to you? So as we looked at who actually responded, we had 30 respondents. It's a very small sample size, but we're looking for themes. No dentists, unfortunately, and only 1 reported that they did not have medical student debt. So of the 29 that we looked at, 9 were already in loan repayment programs, and the pie graph to the far is the distribution of the specialties that were represented. 66% of the group actually practiced longer than 10 years, 34% practiced under 10 years. So in the first question, how do you define financial security? We looked at those who were in loan repayment programs versus those who were not. Both groups identify that they're not living from paycheck to paycheck, being very important to them. This distinction between the groups was that the LRP group, most of their immediate needs were where was most concerning, just trying to get through housing, food, transportation, versus the other group was more long-term desires to just not have to worry about money, having more control with their money, having to pay, save for retirement. And then we looked across how outside 10 years past practice versus 10 years under. In both groups, they definitely wanted to have debt-free again, but there's similarities in the groups in terms of the categories of immediate versus long-term goals. The second question, what does burnout mean to you? In the LRP group, we started seeing mental fatigue, depression, anxiety, a lack of desire to continue in their careers, and most of their very strong language around anger, resentment, and frustration. Where in the non-LRP group, we actually saw more conversations around the same themes, but less of that very strong tone. And then moral injury as an issue started to creep up. And it crept up more prominently as we look at this question across years in practice. And what I saw distinctly between these groups is that moral injury started becoming more defining of the institution, the system that you're working with, as opposed to blaming the individual practitioner. And then the last question, what does an equitable loan forgiveness program look like to you? In the loan repayment program group, they believed and supported that working in health professional shortage areas was valuable. They wanted to pay based on their family size, which was a unique variable that we have not seen before. And they agreed into, collectively, there was a lot of resignation to shorter time commitment for loan forgiveness. In the non-LR group, there was agreement around health professional shortage areas. That seemed to resonate a lot. But there are also concerns about being geographically restricted and forgiving loans that are also for people who really were the most burdened. And those themes seem to come up again when we looked across length of time in practice. Complete loan forgiveness ultimately was related to this, but other things that also showed up was forgiving those, again, who were more burdensome by the debt and who were working in health professional shortage areas. So now the second phase of my practicum focused on looking at the comparison models. Of the 5 loan forgiveness programs that are in California, 2 are national and 3 are specific to California. We talked a little bit already about some of the benefits of Cal Health Cares, which is highlighted in yellow. But if you look at it in comparison to the other programs, it has the largest, number one, budget of $340 million. It allows increase the largest number of recipients annually, compared to the length of time that they're actually going to be committed. So for example, Stephen Thompson's, they commit 3 years, and Cal Health Cares is 5 years. They both look at recruitment, retention, and diversification of the workforce. Now, if you look at the national programs, this is important because the federal budget appropriations bill is offering $2.7 billion on workforce development and healthcare workforce, beefing up the healthcare workforce. So these are the 2 programs that are going to likely benefit from those funds. However, the NHSC group actually has the lowest percentage of physicians in that program. It tends to favor more allied health professionals and nurses. And the Public Service Loan Forgiveness Program has no data to date that actually looks at physicians in that group. Now, that is interesting and opportunity because as of 2023, they changed their adjustments and eligibility to be more inclusive of physicians. So now that we've looked at the LRPs as well as some of the themes that came out of the prospective exploration, we're around looking at what the framework is the Surgeon General is talking about. There's 5 essential workforce frameworks for mental health and well-being. Of all the 5, the protection from harm, essentially 2 human needs, safety and security, is where we believe that financial wellness should be, but currently the language does not exist to support that. And so that's part of the recommendations. But we still have to do more explorations and evaluation of our study. Again, we had a small sample size. And so phase 2 looks to expand the surveys and the focus groups that we will be interviewing. Lastly, I just want to mention that the American Medical Association does already have 21 legislative bills in around medical student debt. 4 of them are really key initiatives that we should be taking a look at: adopting an instrument to measure financial security, reducing the PSLF from 10 years to 5 years. And my favorite, public-private partnerships, thinking about, imagine being at graduation at Morehouse and someone says, you've eliminated all your student debt, right? We can do that too in healthcare. But for me, my ultimate motivation, the last thing I want to leave you with is the reason of why I'm here.
U.S. physicians have some of the highest suicide rates of any profession. We lose 300 to 400 physicians a year. So that's on average 1 physician lost to suicide a day.
Staff is dying. It's hard not to have that affect you.
Being on the front lines, it was tough. And it was great when people thought we were heroes.
The heroes that we keep praising, we need to treat them more like humans.
You're always expected to be the hero and to be able to control the situation. But are you a failure because you can do that in your own life? Does that negate everything else and everybody else that you know?
So in summary, at the end of the day, these are real human beings behind the work that we do. You know them, you love them, and the goal of this work is actually making their lives and saving some lives. My next chapter was continue to do this research work and produce original content for Project Recess, spotlighting physicians navigating leadership and moral injury, and enjoying some quality time with my son, who has big hoop dreams and soccer mom plans for me. And I just want to thank everyone who's been part of my journey here. It's been incredible, and I appreciate it. And I appreciate Dr. Joan Reed for her patience in dealing with me. Any questions?
That was amazing. I love the video and the work that you're doing. So I did public, the local service forgiveness, and I was forgiven 2 or 3 weeks ago. And I'm surprised, and I wonder if you can tell us why the people who are not in the loan forgiveness program, and they've been out of medical school for more than 2 years, technically those people would have been forgiven.
Exactly.
Score, but in PSLF, why are they less angry than we are? Like less than 10 years, like why? And do they not have loans? I remember when I was in medical school, some of my colleagues who were going to surgery, ENT, like, it doesn't make sense for me to do the public health service loan forgiveness, to go to a nonprofit where I can do private practice and make so much more money and pay off my debt in less than 5 years. So is that what's happening with that group? What's going on?
Well, first I will have to say, great question, and congratulations to you. Let's just talk about that. I think there's one, this is important because this is a small sample. So the most important thing is that we need to keep doing these surveys, and we need to build instruments that are actually going to measure the why. What I can speculate is 2 things. One, the perception that you will do better in the beginning is what we're telling our medical students, our residents. Don't worry about the debt, just do it. So if you see this group, only one reported that they did not have student loan debt. So it's not that people in this other group don't have student debt, but their perception of their ability to manage that debt is somewhat skewed by what we say. And what we're seeing is 10 years out, even 15 years out, people are still carrying large percentages of debt. Remember, if we think about, this is a mortgage, 6 figures. So how long do you typically see mortgages be paid out? But for some reason, we're not driving home the reality and the practicality of that. And so they are missing out. And the other part of that question is the public service loan forgiveness program. Before 2023, some states, California and Texas, had this barrier where in order to be eligible for PSLF, you had to be associated with a nonprofit institution. So people assume hospitals, nonprofits, no brainer, right? But most physicians are hired by medical groups, and the medical group is attached to the hospital. So therefore, as a physician attached to a medical group, you don't qualify for PSLF. And that was the workaround. And PSLF, there was actually legislative debate to exclude physicians because the perception is they're going to be fine. So there were some laws built in to exclude. And just until July 2023, California removed that and created that adjustment. So it's a very interesting time now. Yes.
Thank you. You know, we recently did a survey of the fund at the Commonwealth Fund, lawyers at the Commonwealth Fund, sorry. At the Commonwealth Fund surveying healthcare workers, including physicians, about discrimination. And one of the things which we found also, which other studies have found, just the impact of discrimination, bias, witnessing racism on burnout, stress. And so I'm just curious, as you're moving forward with this work, what are your thoughts about integrating some of those questions as well? Because we also saw a distinction between younger healthcare workers who were more likely to report witnessing discrimination, more likely to have words about it, more likely to be centered and sort of how to communicate about equity than physicians who are older, who may not necessarily have that training, they may witness it, but may not necessarily have the words for it. So we'd love your thoughts on that.
Yeah, great question. Thank you. What's happening right now at UCLA and with Physicians for a Healthy California is there is a study that's looking at women physicians of color and their impact, how burnout is impacting them and how they define that. And it includes looking at moral injury. What I think needs to happen is that there needs to be multi-center evaluation of this questions. What is this tool that they're using? Can it be used here at Harvard? Can it be used here at other institutions, especially? And also comparison to historically Black institutions, Black colleges and universities, and what is their experience and is there a correlation? Because if we look historically, the number of physicians of color have actually declined pre versus post segregation. We start to wonder what was that model look like to have be in an environment of people who you may identify with culturally and feel like are supporting you, now being in an environment that has changed. So there's a lot of opportunities for research in that. And the other piece of it is I also, and this is why I moved into the art and film space, is that sometimes there's just no words. And being able to walk someone's shoes and display that on film says more than being able to just ask them a question in a survey. And that's why Project Recess, I believe, is a valuable tool to begin to tell those stories in a more qualitative and enriching way that it reaches everyone.
Hi, congratulations, great work on at least one part of burnout. I'm a regional administrator for HRSA, the Health Resources and Service Administration, and we work with the National Health Service Corps. So first of all, I am so impressed you have the latest numbers. Yes, you know.
Had to do some digging.
The conflict that I have is I am always encouraging physicians to go into primary care, to work in underserved areas, often minority physicians, so they reflect the patients they see. But we know from surveys and your own work, primary care has the highest burnout, lowest income, most responsibilities. And my conflict is I am attracting minority physicians into a field that has this baggage. So how do we reconcile? The country needs more primary care. How do we reconcile it? Do we do it piecemeal like this, do a little bit of loan forgiveness, do a little bit of training not to burn out? I'm lost. I don't know what to do.
Thank you for your question. It really highlights a couple things that I think we think innovatively to transform our thinking around what the country needs in terms of how the healthcare workforce. Much like the value-based care system model, our patients need all of us. They need specialty care. They need someone who's going to care and connect them to resources and be the person that's going to be there. And what is missing is this model of loan repayment is we're only focusing on primary care providers. And what we saw differently that Cal Health Cares did through PHC is that they actually gave loan forgiveness to specialty care providers as long as they're working in medically underserved areas. And that's especially the ophthalmologist is important to have in areas and being able to provide that as a referral. So I think changing our scope of understanding of like just primary care. And I think doing that also helps our primary care providers because then they don't feel like they're out there on alone on an island trying to solve all the world's problems for their patients, but they actually have specialists that they can refer to help support the work that they're doing for the patients in the community. And I think the other thing that is important to note is to understand that collectively, when we serve our collective community, it raises all boats, right? And the idea of that just primary care providers need the help is that's the fallacy. I think that's what we keep saying. Reality is all those physicians who, at this point in time, post COVID, if you're still in the healthcare game, it's right. You probably need support and we need you. And so I think we just need to change our mindset about how do we bring the collective and what does the collective look like?
Thank you. Last question, and this is coming from online. For the fellows, it's coming from Jay. Oh. Amazing work.
Jay.
Such an important challenge and incredibly mixed methods presentation. Do you have plans to publish this work as it would be an important contribution?
Any publications? Yes. Going back to like the next steps is really to complete the work and increase the number of surveyors, as well as also join other studies that are happening across the nation, because it's important to show the numbers. But then like I said before, the qualitative. So I'm also interested in producing the work in forms of film. So Jay, if you have any contacts at Deloitte, thank you.
Thank you very much.
Thank you so much.
I think we have the other piece. Tom Lee, last night, talked about using New England Journal Catalyst as a vehicle for getting out innovative thinking. Our next presenter is Jody.
Thank you. Good morning, everyone. I am absolutely honored to be here and excited to present our practicum on transportation insecurity and flu vaccination among pregnant people in the United States. To provide some context, I am an infectious diseases physician, and I actually started my infectious diseases training at Mass General in July of 2020, so right in the midst of the COVID pandemic. And what really stood out was that pregnant people I was seeing on the ward on service, they were experiencing really poor clinical outcomes compared to their non-pregnant counterparts. Wouldn't be a Zoom call without technical difficulties. Is it projected on the? Thank you. Right, so pregnant people that I was seeing that were really ill compared to their non-pregnant counterparts. And in addition to this, we were witnessing low COVID-19 vaccine uptake among this group, particularly as they were excluded from clinical trials. They had a lot of lack of safety data. And also there were significant racial and ethnic disparities that were present. Just to represent this graphically, we can see here on our y-axis is the vaccination coverage, x-axis is over time. And by January 2022, even though vaccines were available since December of 2020, you see that vaccine uptake in this group was still just 41.5%, which is less than half of the pregnant population was vaccinated. And if we look at the different racial and ethnic groups, which are color represented here, the non-Hispanic Black population represented in green consistently had the lowest uptake, and by that time it was 25.5%, followed thereafter by the Hispanic population represented in purple, that was just 37%. And then when we look at the clinical outcomes, at the maternal mortality, as you know, in the United States, we're already experiencing one of the highest maternal mortality rates among all high-income countries. We see on the y-axis maternal deaths, and the x-axis is the different racial and ethnic groups. The blue columns represent pre-COVID and the orange columns represent during COVID. And we see the excess of deaths for all groups occurring during COVID, but it was particularly high among the non-Hispanic Black population as well as the Hispanic population. But this problem of poor clinical outcomes related to vaccine preventable diseases was not just restricted to COVID. This was actually also happening with influenza. In fact, in 2022, among all reproductive age women who were admitted for a flu-associated hospitalization, 50% of them were pregnant people. And despite this, flu vaccine uptake has also been low and has been on the decline year over year. As we can see, the last season had the lowest uptake in the last 3 years at just 47.2%. So this was really the inspiration for me to work with my host organization, which was the Infectious Diseases Division at Mass General. And in response to our institutional request for proposals, the United Against Racism Health Equity Improvement Project, we conceptualized the Vaccine Equity for Adult Vaccinations Project, and particularly maternal vaccines. And we wanted to mirror the activities that were being done by the state COVID-19 Vaccine Equity Project. Particularly at the state level, they had priority populations. The third priority population they had was individuals who did not have access to transportation. And this really, as we started designing our project, brought up some important gaps in our knowledge. First, transportation insecurity, what was the definition? So it's a lack of access to safe and reliable transportation. But what we didn't know is what was the prevalence of transportation insecurity among pregnant people in the US, right? We had no data on that. We also didn't know what the relationship was between transportation insecurity and flu vaccination. So to fill these gaps, we do what we do, back to basics. We did a literature review, and we also did extensive stakeholder engagement where we really wanted to engage multiple sectors, including transportation engineers, public health agencies, obstetricians, nurses, midwives. We spoke to everyone that takes care of pregnant people. And what we found was that the prevalence of transportation insecurity among the pregnant population was unknown in the literature. We didn't have any data on it, but we did have some data on the general population in the United States, where the prevalence of transportation insecurity was around 24%. There were some important predictors of transportation insecurity, including urban versus rural status, where urban residents were more likely to have transportation insecurity, primarily because they were more reliant on public transit versus rural residents who were more likely to be car owners and so less reliant on public transit. There were also differences with income, with low income households having a higher prevalence of transportation insecurity, and racial and ethnic minority groups also having a higher prevalence of transportation insecurity. There was a lack of state-specific data on the prevalence. We had some preliminary institutional data at MGH where the prevalence was surprise, much lower than the national average. So it was just 7.8% in the primary care population. And when speaking to the nurses, the main way to mitigate transportation insecurity, particularly for Medicaid patients, was through the PT1, which is provider requests for transportation. However, the nurses reported that this was quite a cumbersome process, especially for specialty areas. They had to contact the primary care physicians or the social work department. There was a large turnaround time, and it was often not in time for the patient's appointment. They found the process of Uber vouchers much faster and easier. However, this was not widely available. It was restricted to certain programs. We also, in the data, in the literature, found that transportation insecurity was associated with flu vaccination in the primary care population, where adults with transportation insecurity were 45% less likely to receive their flu vaccine. However, the relationship between transportation insecurity and flu vaccination, specifically in the pregnant population, there was no data on that. What we do know about pregnant people is that they're more likely to receive their flu vaccination at these top 3 locations. So number 1 is their OBGYN office. followed by the hospitals and their primary care offices. And that's really because pregnant people trust their healthcare providers the most for vaccine information. We also know that pregnant people have unique transportation challenges, one due to their physical changes that they're undergoing, so swelling of the legs, compression of their diaphragm, it can lead to some shortness of breath when they're walking, especially as they're trying to climb upstairs. It may be very difficult for them to get around these public transit facilities. There are also some risks that come with public transportation. You have exposures to infectious diseases. Recent pandemic was evidence of that. And then there's some environmental and infrastructure challenges. So it may be overcrowded. There may not be adequate seating. There also may be malfunctioning amenities such as no water in the restroom. The elevators aren't working. One thing that stood out when talking to all of the stakeholders was before we even get to transportation and flu vaccination, we really need to consider the question, do pregnant people have access to high quality prenatal services? And I really thought that was the first pillar that we needed to consider before moving on to transportation. Are they aware of these nearby services? And so just to summarize that in a schematic, to get the pregnant person to the vaccine location, we first need to consider their awareness of the prenatal services and their ability to access it, particularly if we consider public transit routes that there may not be routes going through certain neighborhoods. They may have to walk a long distance or travel a long distance to get to a route that travels to their destination. Then the different modalities of transportation, and transportation itself is fraught with multiple challenges. So this brings us to the aims of the practicum, which one was to determine the prevalence of transportation insecurity among pregnant people in the US, and then also to determine the relationship between transportation insecurity and flu vaccination among pregnant people in the US. To do this, we looked at the 2022 Behavioral Risk Factor Survey Surveillance System, which is a national survey issued by the CDC. It measured, we chose this specific survey because in 2022, for the first time, it included the social determinants of health and health equity module, which started asking questions about transportation insecurity, food insecurity, ability to pay your bills, and other social drivers of health. The population in our final data set was 1,428 pregnant individuals, which represented a weighted sample of over 1 million pregnant individuals across 42 US states and territories for the calendar year of 2022. Our exposure of interest was transportation insecurity, and our outcome of interest was flu vaccination. And we also collected data on important covariates. For statistical analysis, we looked at bivariate associations between sociodemographic variables and transportation insecurity, as well as sociodemographic variables and flu vaccination. And then finally, we used logistic regression to estimate odds ratios and 95% confidence intervals for the association between the two. And we used a change in estimate approach to assess for potential confounders. So these are the results. This is our table 1, and we can see our transportation insecurity represented in light blue. And to point out, individuals aged 18 to 24 had the highest prevalence of transportation among all age groups. Specifically for race and ethnicity, the non-Hispanic Black population had the highest prevalence at 20.5%. For urban versus rural, this was in keeping with the literature, where urban residents had a higher prevalence of transportation insecurity compared to rural. And then for health insurance type, there were, among the uninsured, they had the highest prevalence of transportation insecurity at, this is being blocked, it's 29%. By far, the strongest predictor, however, of transportation insecurity in bivariate associations was income. So for individuals earning less than $25,000 per year annually, the prevalence was 22.6 compared to just 1.3% among individuals earning $50,000 or more. And when we look at the prevalence of flu vaccination stratified by income, It was lowest among individuals earning $25,000 or more at just 3.9%. And it was highest among individuals earning $50,000 or more at 50.2%. And for a final outcome, we found that flu vaccination uptake was just 16.3% among individuals with transportation insecurity, compared to 40.7% in those who were transportation insecure. When we did our unadjusted model, we actually found that individuals with transportation insecurity had 72% lower odds of flu vaccination compared to people that were transportation secure. However, adjusting for income greatly attenuated this relationship. So this brings us to our potential policy solutions, the first of which is to address that first pillar and increase awareness and access to high quality prenatal services. And I will say the Omnibus Act is a very comprehensive bill that addresses this. It addresses all the social determinants of health. It addresses the perinatal workforce. And the last bill in that composite is specifically on maternal vaccinations. The second thing is to bring the care to the people. You know, we need to expand programs like prenatal home visiting programs, mobile prenatal clinics. We should also have options for transportation to services, especially those options that are less cumbersome for nursing and work staff. And then we should also consider modifying public transit to accommodate pregnant people. And my dear friend and fellow colleague, Henny from South Korea, pointed out that in South Korea, they actually have designated seating for pregnant people under public transit systems. And I thought, well, that would be really cool if we had that here. And then finally, to supplement income. Seeing that there is such a strong relationship between income and transportation insecurity, this can be another method that we think of. The next step, specifically at Mass General, is to, in response to the Joint Commission's mandate. So as of last year, the Joint Commission has mandated that all hospitals need to start collecting health-related social needs data in order to retain their accreditation. So Mass General has started that widespread collection of data for both inpatients and outpatients. And so this presents us with the opportunity to actually look at our institutional level of transportation insecurity among the pregnant population at MGH and determine the relationship with flu vaccination in our population. With all policies, we always need to consider the patient preferences, the cost, the ability to scale, and the sustainability. And of course, it involves multiple sectors, multiple people that are dedicated to the pregnant population. I'd like to thank all of our stakeholders and everyone that really helped to make this project possible. Thank you.
Morning, excellent presentation. I was struck by a couple of statistics that you shared, particularly the association between income, transportation, and security, which might be intuitive. I was looking at it through the lens of, if you think of income, low income also is tied to eligibility for Medicaid. And so it'd be interesting, and I recognize this is more cross-sectional in nature, to look over time to see if there has been a change or reduction in transportation insecurity amongst those who are low income and Medicaid recipients. Because for those of us in the Medicaid space, there are value-added benefits that members, patients may not be aware of or underutilizing, such as you mentioned on one of your latter slides, transportation vouchers, gas cards, et cetera. And particularly in my organization, we've seen high utilization of those. And so it'd just be interesting to see, particularly for those, again, low income Medicaid recipients, are we making progress based on some suggestions like you had, utilization of mobile vaccination vans, which we do, gas cards, vouchers through Uber transportation. But excellent work. Sure.
Thank you so much. I absolutely agree. You know, the Joint Commission making this a mandate, I think, is a strong move so that we can actually start associating these policies, the Medicaid policies and their benefits, with hard evidence of improvements in either clinical outcome reduction in transportation insecurity, and really it's a way to evaluate how well the program is doing, how well is, Medicaid serving these needs. Particularly, I would say, looking at Massachusetts, I had contacted the Department of Public Health and just realizing there's often some disconnect. So in 2022, there were 30,000 pregnant people in Massachusetts on Medicaid. And once you're on Medicaid, you're below a certain income level. And only 4,000 of them were actually getting maternal cash benefits. And that's because those, to be eligible for that, you had to be in the 3rd trimester of your pregnancy. That's one of the stipulations. And so just understanding what the roadblocks are and what prevents people from getting their benefits is helpful, and monitoring it over time. Thank you so much. Oh, I'm sorry, Dr. Reed is alerting me that we can only take 2 more questions. I apologize.
Hi, so I'll be quick. And I'm actually a little bit going. Thank you for that timely presentation. Also want to congratulate you on your Bachelor of Medicine, Bachelor of Science.
Yes.
That's really a University of West. I wanted to talk about whether you had an opportunity to look at patient health belief system, because the uptake of immunization in my practice, immunization advised, immunization not given, and then you say the reason why. So I probably have the data on usually patient refused. I come from Michigan. We have like the worst public transportation system. So I hear what you're saying, why my patients can get to their ultrasound or even their visit. And behold, when they go into labor without transportation, they end up at some of the hospital, other than the one where I deliver. But I do want to point out the good thing that we have in Flint as an ecosystem for many pigs, right, apart from the water crisis. There's a cash transfer program out of Flint, and the moms are eligible once they enroll in prenatal care and for the 1st year of the infant's life.
That's awesome. That's amazing. Yes, I agree. In fact, most of my work during fellowship was about vaccine hesitancy in pregnancy, and even despite recommending it, the mistrust that pregnant people have. And I said, it's very much logical mistrust, because if there's no safety data available, if they're excluded from these clinical trials, it is very reasonable for them to be, worried about harms of these vaccines to their fetus. And so one thing that definitely improves vaccine uptake and vaccine confidence is a healthcare provider recommendation. There was a study out of Mass General that said it increased it by 5 times. They were 5 times more likely to take the vaccine once it was confidently recommended by their healthcare providers. But that comes back to, how do you induce confidence in the healthcare providers? Because some healthcare providers themselves were like, I'm not sure if we should be recommending this vaccine. So it's very much a system level change. It starts by at least getting good safety data on the vaccines, and including pregnant people in vaccine clinical trials, which is another bill called Safe Medications for Moms bill that's being worked on. But I hear you. It's multifaceted. Vaccine confidence is very much a big part of vaccine uptake in the pregnant population. But I also want us to acknowledge that there are other social factors that may be influencing vaccine uptake as well.
Hi, my name is Jackie Graham. I'm a maternal fetal medicine specialist, and I have worn several hats. But one hat, when I was public health director of a large 14-county South Georgia district, we did group prenatal care. And what I found in that setting was we had a really good vaccine uptake by discussing that amongst a group, and people could air their concerns openly in the group, and then there was maybe a little bit of groupthink. But anyway, we had a really good, and that was a very low income, mostly African-American population. And then we did another group prenatal care in a migrant farmer population. Now fast forward, and I do maternal fetal medicine. And what I found is that and I want to know if you've looked at this, is a lot of the private practices don't offer vaccines in their private settings. So I find that when patients come to me from that setting, there is less vaccine uptake, flu, COVID, everything. And a lot of these patients have to, with the transportation, and that really got some things thinking for me, some things going. A lot of these patients, it's not just getting to their primary OB, they would have to go somewhere else to get that vaccination. So have you looked at that in terms of uptake? The number of OB providers that don't offer vaccines in
In
their
office, yeah. Excellent point. And I, did not look at that in the pregnant population, but certainly as an infectious diseases physician, there are many vaccines that are recommended. Shingrix, for instance, that is not available in the shingles. It's not available in the office, and we have to then tell our patients to travel to the nearest pharmacy, and that obviously is a disruption in the ability. So I absolutely think having in on-site vaccine has been, and that's well documented in the literature, on-site availability of the vaccine absolutely increases vaccine uptake. And so to have that as a policy solution is very appropriate.
We get a round of applause. For Jody and Nana, excellent, excellent, excellent. We're going to take a 5-minute, very brief break, and we're ready for the next session to start. So please don't go far. Our next session will include 3 presenters, 2 faculty fellows, and 1 postdoctoral fellow. Our first presenter, which will be virtual, is Nathaniel Harnett, a neuroscientist whose research is focused on understanding the brain basis for why some people are more likely to develop stress-related disorders, such as post-traumatic stress disorder after trauma. His current work leverages magnetic resonance imaging techniques, including functional MRI, structural MRI, and diffusion-weighted imaging, to identify multimodal neural signatures of PTSD susceptibility in the acute aftermath of trauma exposure. Next will be Michael Flores, an instructor in the Department of Psychiatry at Harvard Medical School and a research scientist in the Health Equity Research Lab at Cambridge Health Alliance. His research employs rigorous analytic methods to inform policy development, allocation of limited resources, and to improve the health outcomes and care quality of racial ethnic minorities with behavioral health disorders. And our third presenter is Jason Marvin, a Dean's Postdoctoral Fellow in the Center for Regenerative Medicine at Massachusetts General Hospital. They received their BS and PhD in biomedical engineering from the University of Texas at Dallas and Cornell University. As an aspiring independent investigator, they aim to complement their bioengineering skill set with genetic and developmental biology approaches to uniquely guide the development of mechanistically informed therapeutic interventions for promoting effective tendon healing. And with that, our first presenter, virtual.
Hello, good morning. I think there's a bit of a time zone difference. I hope all is well. I don't have video sharing access, but let me just go ahead and share.
Just 1 second. Can you give video sharing access, please? 1 second, somebody with those fast IT fingers.
Okay, perfect.
Hello, Nate.
Hello, thank you so much for having me, and thanks for accommodating me virtually. Are my slides appearing okay?
Not yet.
All right.
Now they're here.
Perfect. All right. Thank you again for accommodating me. I apologize. There was some extraneous travel I could not get out of and have to be virtual today. So what I will do with the time that I've been giving is talk a little bit about what we've been learning in terms of the impacts of structural racism on threat neurobiology and why we've been focusing on threat, why it's so important for PTSD and other related disorders, and how over the last couple of years, we've been really trying to hone in on how early life inequities and experiences might be affecting the neurobiology that we think is really important for being able to predict who's going to go on to develop PTSD or not. So when I talk about threat neurocircuitry, I'm really talking about 5 brain regions that over many, many years of research, we're really pretty confident are really mediating how we learn what is threatening in our environments, how we express the emotional response to threat, and how we regulate ourselves in different contexts. And so we're really focusing on the amygdala shown down here in blue, which is really important for forming associations between cues in the environment that predict a threat's about to occur and the threat itself. The hippocampus, shown here in red, is really important for contextual modulation of these amygdala-mediated fear memories, for learning that if we're out in the woods, we're in a potentially dangerous situation if we hear the hiss of a snake, but if we're sitting on our couch watching Animal Planet, that's probably a safe situation. And then different components of the prefrontal cortex help to support different cognitive and affective processes to either exacerbate that emotional response or regulate it, sort of pump the brakes on it, depending on the context that we're in. And we also know through many different years of research that this threat neurocircuit is sort of transdiagnostically important for psychiatric disorders. If we look at meta-analyses published related to anxiety, generalized anxiety disorder, major depression, or post-traumatic stress disorder, all of these different disorders really seem to have a neurobiological basis in disruptions, both in terms of function and structure of this underlying threat neurocircuitry. And so we think it's really important to understand what are the sort of influences on the development of this structure and how it responds after traumatic stress to help understand how we guide precision medicine approaches towards early prediction and treatment of these different disorders. But one of the things that we know very acutely is that early life experiences shape brain development. And we know that these sort of early life adversities and early life contexts in which people are growing up are very highly racialized. So this is data from childtrends.org, and it tracks the number of individuals and the number of children who experience either one adverse childhood experience or 2 or more adverse childhood experiences. And the point of showing this is that it really doesn't matter if you're looking in, say, the New England area, the mountain area, the East South Central region. Individuals who come from racially or ethnically marginalized or minoritized backgrounds tend to experience they tend to experience more adverse childhood experiences than individuals who are white, non-Hispanic. And in work that we've been doing in parallel using longitudinal data from recent trauma survivors, we're really able to see that the context in which people are sort of developing and growing up are different even in these cohorts as well, where we see compared to white individuals, Black and Hispanic individuals are growing up or living in neighborhoods with much more disadvantage. This is less resource availability defined by the Area Deprivation Index, which pulls data from the US Census. We can also measure things using geospatial analyses like the amount of green space or the amount of parks or trees or foliage in their different environments. We see again that Hispanic and Black individuals have less green space in these samples compared to white individuals. And we can tie, I think, these sort of early experiences back directly to health by looking at some prior work that was done by Nancy Krieger almost a couple decades now, really looking at premature death rates and mapping that by where people are getting off on the T. We're at Harvard now, so I think everyone knows the T and all of its various problems. But if you look at stops like Maverick, Dudley Square, and Mattapan, these areas have the highest rates of premature death. And if you overlay the racial and ethnic demographics of Boston on top of that, you really see that areas like Maverick, largely Hispanic, Mattapan, Dudley Square, largely Black. And so the environments that people are living in, the environments that they're developing in, are associated with adverse health outcomes that we really want to pay attention to. And as neuroscientists who are really concerned with developing predictive tools to help understand who's going to develop these different psychiatric disorders and how we actually treat them, it's really important for us to consider the types of biases that we introduce when we're not paying attention to appropriate sampling, how our different analysis decisions might lead to what we call different neurophenotypes of psychiatric disorders. And by failing to really encompass or capture the wide amount of variability in the experiences that people have, we run the risk of making these really ungeneralizable neuroscientific models of psychiatric disease that ultimately aren't going to be helpful for most of the population. And so really what we've been trying to do over the last couple of years is figure out what really are the impacts of different measures of structural racism, these different measures of structural inequities that might be impacting threat neurobiology. We started really leveraging the adolescent brain and cognitive development study data set. And this is a huge data set of about 12,000 individuals who started the study when they were about 9 to 10 years old. It's been about 6 or 8 years now. So they're approaching 16, 17, 18 now. but they're being tracked from across the United States, completing many, many different types of assessment. What we were particularly interested in trying to understand is how do we look at brain imaging data collected from these children, and how do we map that to differences in the experiences and context they have? So this is work done by a very talented research assistant who's now at the University of Minnesota, and she looked at things like family conflict and family hardship, the trauma load of these individuals and their family income or parent education, as well as their parental employment, and again, the types of neighborhoods they're going up and what kind of disadvantage was there. They were particularly looking at, given the sort of socio-historical roots of inequity in the United States, looking predominantly at Black and white children within this sample. And so one of the things that I think is always important to preface with, and one of the things that we saw and kind of expected to see, is that when we're talking about race-related differences or race-related variability in neurobiology, we're not talking about skin color, right? We're talking about a collection of social, historical, contemporary influences that mold the environments that people are in that might contribute to altered neuropsychiatric development. And so, as you might expect, compared to white children in the ABCD study, Black children have caregivers with less education and are more often unemployed. They live in families with lower family income, and they're coming from more disadvantaged neighborhoods. They're also experiencing more family conflict and financial hardship, and even at 9 to 10 years old, are having these greater endorsement of traumatic events. It's 9 and 10, so it's not like a huge number of traumatic events, but even at this age, we're seeing a significant difference in the number of traumas that the children are reporting. And so what we did was we looked at gray matter volume differences of this threat neurocircuit, the amygdala, the prefrontal cortex, and the hippocampus, to see, can we see impacts or race-related differences in neurobiology? And then is that accounted for by trying to normalize the inequity between the groups? If we run a series of parallel mediations, if we imagined a world where we didn't have these inequities, can we account for these race-related differences? And so the figure on the top are all the different brain regions we looked at, and the ones that are in yellow are the ones where we do see a significant parallel mediation, partial mediation of the race-related differences. And so basically what this suggests to us is that, particularly within the prefrontal cortex, it's not race that's driving these differences, right? It's the experiences and the inequities between groups that's driving these differences in early life development of threat neurocircuitry that is really important for understanding PTSD and psychiatric disorders. We've been following this up over the last year, really trying to take advantage of the longitudinal nature of the data set, and now looking at these children become adolescents, now that they're about 11 to 12 years old, and trying to understand the different ways in which individual level factors like income or exposure to discrimination, and state level factors like, again, area deprivation, or even new measures like indices of state level racism that Mark Hatzenbuehler at Harvard University has derived from his Project Implicit dataset, how those are related to neurobiological development. And even at 11, 12 years old, these three columns are three different ways of trying to model different brain data. The end result really, though, is that we really do see, even at 11 and 12 years old, these same types of race-related differences. And we also see that there are these unique associations with both individual levels of income and discrimination, as well as state or nationwide level indices of resource availability or discriminatory policies. And really the takeaway here is that, even as we, continue to follow these individuals, we're still seeing that there are these race-related differences. We're still seeing the impact of these inequities as they continue to develop. But just like we looked at before, once we start to account for these differences and inequities, once we start to account for the disparities that we're talking about, we really are accounting for a lot of the differences that we see in race-related neurobiological development. Again, suggesting that it's not race per se, it's really sort of the underlying currents of inequity that drives differences in development and regions that are really important to understand. I've talked quite a bit about brain morphology in terms of volume or thickness, but we also know that there are other types of structural data that we can use to understand how different brain regions are connected. So just very briefly, we've also looked at white matter connectivity that interconnects the prefrontal cortex, amygdala, hippocampus circuit, focusing on regions or tracts like the cingulum bundle, the uncinate fasciculus, and the fornix. And some of the preliminary data we've managed to generate is actually really interesting in that, whereas a lot of what we see with gray matter data is that inequity is associated with lower volume or lower thickness in Black individuals, what we actually see is in really important cognitive regulation tracts like the dorsal cingulum and the uncinate fasciculus, Black individuals actually show greater fractional isotropy, greater white matter integrity within these tracts. And so it's not really that everything has a decrement to the brain is that individuals are living in these different environments and maybe developing different sort of adaptive strategies to cope with the environments that they've been put into, and that might have downstream impacts on psychiatric disorder development later on. And why we think this is so incredibly important is that we've been doing parallel work over the last several years, really looking in young adults and older adults, what is sort of the long-term impacts of these inequities. So in an earlier study, we looked at neurophysiological reactivity. We looked at essentially how people respond to a loud white noise in a laboratory. And you can see this sort of emotional blunting of the neurophysiological response to threat in Black individuals compared to white individuals that we again found was completely accounted for by differences in violence exposure, neighborhood disadvantage, and family income, suggesting sort of an adaptive response to the different environments that individuals have been put into. We've also looked very recently at how these different neurobiological markers might be predictive of PTSD in recent trauma survivors. And the really key takeaway here is that when we fail to account for the differences in experiences that people have, we see these differential associations between brain connectivity and future PTSD symptoms, where Hispanic individuals show this negative relationship, white individuals show an orthogonal relationship, and Black individuals show a positive relationship. So failing to account for the inequities present within our data sets produces these very differing brain behavior associations that are important for us who want to predict PTSD. And the last thing before I end is that we really are trying to move towards a mechanistic understanding of why these different aspects of structural racism or personally mediated racism might drive these differences in neurobiological development and be related to psychiatric disorder. And so we've tried to do a lot of synthesizing of work that's been done over the last 50, 60 years. We're excited to finally have this out and have sort of a resource for the field to sort of look to and say, here's what we know in terms of the neurobiology, and now here's what we have to do moving forward to really understand what we're going to do. And so I think that leaves us mostly on time. I apologize if we went over, but I just want to leave up the acknowledgements, thank all the people involved in the background work. Of course, thank the Diversity Office, the Harvard Catalyst for their support of what I think is some important work.
Thank you very much for that presentation. There's time for a few questions.
Thanks for that wonderful presentation. I'm glad to see finally technology.
Introduction, who are you? We can't see who you are. Can you say?
I'll say who I am.
Stay.
That's too short. Octavio Martinez, Executive Director of Hawk Foundation for Mental Health, UT Austin. Great presentation. What I wanted to comment is I'm glad to see finally technology catching up to showing how structural racism in fact does have an impact on the structural parts of our brain, as you pointed out for everyone. It makes me think about though, what two parts to this. Number one, translationally, how is this going to change how we actually provide care? And two, what are you looking at, and can you opine on what in fact maybe some of the resilience factors between the groups of individuals who in fact do not develop PTSD, though they are experiencing the very same type of ACEs within these same environmental zones?
Yeah, thanks. Those are two great questions. And just as a comment, I'm in Austin now, so it looks like we switched places actually. I think to answer your first question, we've been thinking a lot in terms of emerging neuromodulation therapies for PTSD and other psychiatric disorders. So there's been a lot that's been done in terms of transcranial magnetic stimulation. A lot of our collaborators have done that and have seen some very important and promising results in terms of how we move that forward towards novel treatments for PTSD. The issue that I think a lot of our results raise is that if you look at the last slide of data I presented, is that one of the major stimulation sites we use, left dorsolateral prefrontal cortex, that connectivity pattern actually differs by ethno-racial group. And so there's this fear that I have where if we don't know or understand or haven't been diligent in making representative samples, there's this potential to pick these stimulation sites that in some individuals might actually have a positive impact, but in other individuals is going to have a negative impact because we're modulating a different sort of neural circuit. And I think that from where I'm sitting, a huge point of this research is to be able to try to understand how we make sure the hamster wheel isn't moving too quickly so that we leave people behind. And so from a translationalist perspective, it's really about understanding what are the limits of our generalizability and how we sort of push that forward before we go on to develop new therapies that might impact things. Related to the question on resilience, our lab's been doing a little bit more work in terms of that area. So Kate Webb, whose data I didn't get to show today, she's been looking at sort of, psychological resources or internal resources to adapt how well you feel like you can cope, and how that interacts with different sort of individual resources or the neighborhood level resources, whether that be green space, whether that be the sort of area deprivation index that we were looking at before, and really showing how these things sort of intersect at different geographic levels to promote resilient phenotypes to PTSD. So it's something we're definitely thinking about. We want to get a little bit more in depth in terms of individual factors, but it's definitely on our radar.
Hello, Nate. Thank you so much for the presentation, MGH McLean alumnus. So very, very grateful for your work. Jacques Ambrose, I'm the Chief Clinical Integration Officer at Columbia, and I'm actually a neuromodulator. So I'm an interventional psychiatrist actually doing a lot of the TNS work that you're describing here down at Columbia. And I think I'm especially curious as you're referencing a lot of the racial and ethnic differences as we're looking at the different brain region and brain connectivity. A lot of the clinical work that I do in the novel therapeutic space is looking at psychedelics and the intersection of neuromodulation. And exactly as you're described, we don't necessarily have a lot of diversity in the clinical trials that we're seeing, even in at the clinical trials conducted at Columbia. And I'm curious, as we're looking at the different ways that we're translating this research into the clinical world, I'm curious if you've seen any specific indication that would advise us to either take a different therapeutic approach when we're doing neuromodulation for perhaps children or adolescents or adults of different races.
Yeah, I think that's an interesting question. And I unfortunately don't have a very satisfying answer. I mean, to me, I think we're at sort of, ground zero of thinking about, what we've previously called a reproducibility crisis as maybe more of a representation crisis, and that we just really don't know, in terms of a lot of the new things that we've developed, how this is going to work in terms of other individuals who have been historically, let's say, underrepresented from different scientific studies. And so I think that we've been thinking and partnering with individuals to try to just make sure we are getting representative samples so we can ask these sort of questions. But how and where this sort of starts with the neuromodulatory end, I don't have a satisfying answer. I think the best we can do at the moment is really think about how do we bump up these samples? How do we start doing sort of more granular analyses of the experiences that we have to understand these circuits a little bit better?
Be very brief, because I know time's an issue. I'm Don Goldman from Boston Children's, and this is kind of a technical question based on some review I recently did of this kind of work with ADHD. Were these studies done awake? Were the participants knowledgeable about what the point was, or were they done as was done with the ADHD studies while asleep to get rid of any bias of environmental issues?
Yeah, so I think part of what we want to look at is the environmental effect. And so these participants are all awake when they're doing the MRI. A lot of times we're having them do different cognitive tests, so they're not allowed to be asleep, or else we can't use their data. The ABCD does many different things, and because it's a huge multi-site study, the specific questions aren't necessarily designed for racial discrimination or these other measures. And so it's not clear if they'd be aware that we're specifically going to use that data to look at structural racism in these cases. But I think that, sleep is such an important aspect for understanding psychiatric disease and PTSD. And it's something that we've thought about, how do we sort of integrate that? So I'd like to think more about, how we start using these different sort of, whether or not they're awake versus sleeping, how that might modulate neurobehavioral phenotypes, and how that might be related to different aspects of structural racism.
Thank you for that presentation. I just want to add, this is my own aside as we move to the next, is a concern I have. When we look at anything and we're trying to make correlations that relate to race, ethnicity, and the capacity of our system to simplify and not really stress the kinds of issues that were raised here, where that race ethnicity was a proxy for a whole lot of other things that were really the drivers of the stress and the challenge. And we come from a system that I could see coming down saying, well, this is what Black people, this is, and so how do we ensure that both we are included in this research, these issues are included, but they don't become stereotypes that get used in the system. So our next presenter is Michael Flores. Michael.
Is this a picture? Please, Michael. All right, good morning, everyone. Again, my name is Mike Flores, and today I'll be presenting some of my work that's looking at the impact of Medicaid expansion on medication for opiate use disorder, or MOUD. Oh, should have kept this. So first off, I just want to acknowledge the funding source that without which I wouldn't have the time allotted to actually work on this project. So thank you very much for that. So here, let me start. So opioids account for about 75% of drug-related overdoses in the United States. So when I'm talking about opioids, I'm referring to prescription opioids, heroin, and synthetic opioids, such as fentanyl. And the opioid epidemic has kind of transpired in three waves. The first wave really focused on looking at prescription opioids, which then transitioned to heroin, and then into right now synthetic opioids, which is really driven by fentanyl. And so this transition that happened into illicit opioids was really associated with an uptick in opioid-related mortality for Black, Latinx, and Native American Alaska Natives. And opioids have become one of the prime contributors to the decline in the US life expectancy, and the economic burden of OUD, or opioid use disorder, is estimated to be $787 billion. And that estimate includes things like healthcare utilization, criminal legal involvement, as well as losses to productivity. So despite these burdens that OUD brings, very few people actually use any form of treatment. For example, less than 35% get any substance use disorder treatment, and about 10% receive any evidence-based MOUD. And so among those folks that don't get any treatment and they're using illicit opioids, that increases the risk of fatal and non-fatal overdose, as well as the likelihood of end up in the hospital or any ED use. And so racial ethnic minority groups may be at greater risk of these adverse outcomes that I'm talking about, particularly because of their low rates of initiation, engagement, and retention in MOUD. Some of this is partly driven by the lack of MOUD available in areas that are densely populated by Black and brown folks. So MOUD is a good thing to be on for all kind of like the positive things that are associated with it. For example, reductions in opioid-related mortality and illicit opiate use, improvements in social functioning and life quality, and the reductions in the risk of HIV and hepatitis C. So with the advent of ACA and expansion of Medicaid, a lot of low-income folks without healthcare now had access to health insurance. And so that increased the availability of things such as substance use disorder treatment. Medicaid finances about 4 in 10 SUT episodes and is the primary payer of medication for opioid use disorder in the US. So there currently is some research that shows that ACA is associated with greater MOUD access. However, it's still a little unclear in terms of its relationship with MOUD retention, and it's even less clear in terms of its how equitable are these improvements. So the objective of this current study was to assess the extent to which Medicaid expansion impacted MOUD treatment rates overall and by race ethnicity. And so we had two hypotheses. One, MOUD treatment rates increased overall within racial ethnic groups, excuse me. And two, racial ethnic disparities decreased after Medicaid expansion. So what we used for this analysis, we used the treatment episode data set discharges. Hereafter, I'm going to refer to it as the TEDS for 2009 through 2019. And this data set is pretty nice. It covers a little over 80% of the admissions to publicly funded substance use treatment facilities in the US, and about a little over or about 70% of overall admissions to substance use treatment facilities. So that's private and publicly funded. Our sample population of interest included adult admissions to SUT for illicit opiate use. And we had our treatment and comparison population, if you will, where states that did and did not expand Medicaid in 2014. So our primary outcomes of interest were these two, were MOUD initiation and MOUD retention. MOUD initiation, we operationalize it as having either imethadone, buprenorphine, or naltrexone as part of your treatment plan, and MOUD retention as being on MOUD for greater than 180 days. So in our model, in our regression modeling, we're really interested in two things. One was a two-way interaction, which is between two indicator variables, between the post-period variable and then our Medicaid expansion variable. And then we're looking at the impact across racial ethnic groups. We're interested in a three-way interaction between the post-period Medicaid expansion and a categorical variable for race ethnicity, with white being the reference category. So here's a host of covariates that we included in our model. We included demographics such as age, sex, indicators for comorbid mental illness, and continuous state level factors, including prescription opioid availability, synthetic opioid and heroin-related death rates, and state mix effects. So just to let you know, some of these aren't available in the TEDS in case folks are interested in that. So a lot of these things we merged from different data sets. For example, we included the related death rates from the CDC Wonder website. We included prescription opioid availability using the ARCOS data set. So we did a whole kind of combination of data sets to do this analysis. And so our statistical approach for this was the difference in differences to assess the impact, the overall impact of Medicaid expansion on MOUD outcomes. And we used a difference in differences approach for when we wanted to see, I know, right? You just keep on going to see the impact among racial ethnic groups. And so what you see here, I showcase two different analyses, but for the purpose of this presentation, I'm only focusing on the primary analysis, because if not, we would be here for way too long going through all the different tables and things. So I'm not gonna do that. So our primary analysis aligns with our hypotheses, where we're assessing the extent to which Medicaid expansion impacted study outcomes overall. And then we're also assessing the extent to which racial and ethnic disparities in OUD treatment were impacted by Medicaid expansion. And in secondary analysis, we also re-estimated our regression models and conditioned on folks not having any SUD treatment. So essentially, we're looking at novice patients going to services. And then we also wanted to see the long-term effects. So we're not just simply looking at this pre-post, but now we're breaking it down and seeing what are the long-term effects of Medicaid expansion. All right, so I kind of rushed through that because I wanted to go through these graphs, and I'm pretty sure it's going to take me a little bit longer as they describe everything. So here are just unadjusted rates of MOUD initiation and retention. This is just overall in our whole sample. So what you see here, here we go. So here, this is the MOUD initiation among expansion states, which trucks here around 7, and it goes through. This red line just signifies when Medicaid expansion was implemented. And you see it just kind of truck down over here to about a little close to 15, close to 16%. And then you see here in, non-expansion states, you do see MOUD initiation to be significantly lower right around here. And even then after the point, you still see it to be, starts around 3 and it ends around, sorry, doing the 2-screen thing is really messing with me right now. It's around 5, a little higher, close to 6. And then we see here with retention expansion states, we also see that to be higher than non-expansion states, where you see it start around a little bit above 2 and it ends a little above 4. And then for non-expansion states, you see that around 1%, and that tracks pretty similarly across the whole time period. All right, so here's our our first difference in differences analysis. So the blue line that you see here are initiation rates in the pre-period for expansion states. The orange line is the MOUD initiation rates for the post-period. And then you'll see this for non-expansion states too. The gray bar will be the difference between the pre and post. So between these two periods, you see that. And then you'll see me commonly refer to that as the within group difference. And then you see here, this gold bar is the difference in difference. All right. So let me walk you. So then this is what it is. So let me walk you through. So then here you'll see that in expansion states between the pre and post periods, you'll see that there is a significant increase in MOUD initiation in expansion states. And then when you look at non-expansion states, you see that they're always between the pre and post period. There's also a significant increase in initiation. But when then you take this gray bar here and this gray bar here, you see that between the pre and post period, comparing expansion and non-expansion states, you see that there's a significant increase in expansion states for MOUD initiation. And here we're looking at MOUD retention rates. And so similar to the last one, all the bars represent the exact same thing, where the blue is the pre, orange is the post, gray is the pre-post difference or the within group difference, and the yellow yields us our difference in difference. So again, here we see that between the pre and post periods, we see that there is a significant increase in MOUD retention for expansion states. However, we see that between the pre and post periods for non-expansion states, you actually see that decreases between those two periods. You can tell that also by just looking at the blue and orange bars here. And so then when you compare the two gray bars here, you see that there is a significant increase in MOUD engagement for expansion states. All right, so now this is a lot. So I'll walk you through this. Okay, so I'm going to take this first one. So all the colors still coincide with the previous one, where you see that the blue is the pre, orange is the post, gray is the within group difference, gold is the difference in difference, and now we have a new color introduced, which is also blue, but more like a chartreuse. I'll go with is like the difference in difference in difference. So for example, you're going to see that throughout this group, you'll see that with the within group, meaning the between the pre-post, for each group, essentially you'll see an increase. So for the most part, there is an increase in MOUD initiation across all racial ethnic groups, and also for the except for the most part across all. And then when you see this dip and diff now this dip and diff is no longer between those in non-expansion states and expansion states, but it is between expansion state, let's say expansion state white group and non-expansion white group. So then you're comparing those two groups, these two gray bars, to see that gold bar here. And then when you want to then compare, for example, the Black population, you're going to see this bar here. So what we're comparing here are these two gold bars that are right, this one right here and this one right here. So this bar going down is a little bit misleading. It's kind of showing you that it's actually going down, when in reality, it's just that the gains that they have are lower. That's essentially what's driving this thing. It's essentially each one has a value. Like for example, here you'll have expansion group white, Latinx group. You'll have a gold bar that did go up between the pre and post period, comparing those here and here, but you see the gold bar increase. But yet compared to the expansion white group, you see that it actually decreased. So you see here that for Black Latinx groups between the pre and post period relative to whites in expansion states, they actually have initiation rates are lower and have decreased, are lower. However, when you look at the Native American Alaska Native group, you see that it actually increases between the pre and post period, comparing expansion Native American Alaska Natives to expansion white. And then we're looking at retention. You see, I'll just cut to the main findings. We find that we only see a minor decrease among the Latinx group, and then we do not see any significant changes relative to whites. However, you do still see within group changes that are positive, that it is increasing between the pre and post period for expansion and non-expansion states. So here's a nice little summary just to tell you everything I just showed you in a very condensed way, where you do see that overall you see MOUD initiations increase over time between those two time periods, and you see MOUD retention also increase. And then when you look at our analysis by race ethnicity, you find that there is no differences for the Asian population. We found that initiation gains were lower for Black relative to white individuals. And we also see that Latinx had the same negative lower gains. However, we saw higher gains for Native American Alaska Natives. And then concerning retention, we found that Latinx had lower gains. So why are we not seeing similar gains in MOUD initiation? Well, some of this might stem from plan coverage and how that's actually paid for, in the sense of there might be utilization management things. So these are ways to kind of save cost in a way where they have potential ways of starting at a lower dosage for MOUD, for buprenorphine. You might see and wait till it really needs to get to a higher uptick before you actually get more. So people might drop out sooner because they're not seeing an actual effect of the bup. Another might be medication availability, which I kind of touched on really briefly earlier, where studies of Medicare and Medicaid have kind of found that there are fewer buprenorphine prescribers in areas that are densely populated by Black and brown folks. Also, there's a colleague at USC that's looking specifically at pharmacies and how pharmacies that are also in populations that are densely populated by Black and brown folks, they're less likely to stock buprenorphine. So these are some of the reasons why you might not see the same initiation and uptick among these populations. Another is stigma. Stigma is very hard among these populations in terms of it being viewed as a crutch and something that that is viewed negatively. And this is sometimes not just by family members and friends, but sometimes in certain parts of this country, it is viewed as by the people that are actually there to provide substance use treatment are viewed very negatively and have negative connotations towards people that are seeking those kind of types of treatment. And there's also patient preference, which sometimes is driven by stigma, but sometimes it's just regular patient preference, and they may not actually be there at the point where they're ready to initiate MOUD. And so why are we not seeing similar gains in MOUD retention? Well, there's some traditional barriers to care that we all kind of have encountered with patient populations, which is transportation, childcare, inability to leave work to get these things. And then some of these problems might be a little bit harder for populations of color. And some of this might stem from, I was just describing how there's an limited supply, or there might not be buprenorphine suppliers in these areas densely populated by people of color. However, there are still a lot of methadone facilities that are there, and those are the ones that are the primary supplier of MOUD. It is quite burdensome for these kind of treatment regimens where you need to be there on a daily basis to get your services. And so that proves very difficult and very daunting for people who experience transportation, childcare, and work and have work. So here's some potential ways to improve equity. Some of it started coming through after the COVID well, as we're kind of still living through COVID, but there was a lot of kind of policy changes in terms of how telehealth was started to get funded through like Medicaid, Medicare, and become a way to potentially prescribe MOUD and deal with it in that way, opposed to having to show up for like methadone. Expanding Medicaid to the incarcerated. So there was, I think, Massachusetts, and I think it's already passed, but there was a part of the Medicaid demonstration waiver where essentially they were trying to provide inmates with Medicaid prior to their release, or getting them prepared to apply for. So okay, let me take a step back. When individuals go into be incarcerated, they lose their Medicaid eligibility immediately. So then they don't have access to it. And so it's been found that they are less likely to then, once they are released, to go back on Medicaid and to get services. And actually there is this, I think it's over 100% increase in opioid fatalities after people are released from incarceration, because one, they were detoxed and now they are gone cold turkey. So now they are released and they want to use opioids at the same level they were prior to incarceration. So then this leads to an automatic fatal overdose. So that's one thing that they're trying to do, is by expanding Medicaid coverage to that population. Local programming that's very mindful of language and culture. Another is incentivizing equity. So by that, I mean looking at value-based payment policies and how they're actually financing services, meaning not only should they be funding or are they reading certain metrics and quality of care, but also providing a financial incentive for those quality measures to be meeting equity metrics. And that's it. Thank you.
There's time for one question.
Thank you so much for your talk. I oversee one of the substance use treatment clinic down in Columbia with Columbia Psychiatry. I think one of the things that we saw quite a lot when you were talking about patient preferences for opioid replacement therapy is for those who currently have employment or are underemployed. Oftentimes, the employers will have periodic screening for urine drug screening. And a lot of patients are very worried about the stigma of having the quote unquote positive urine drug screen, despite having documentations and having letters from us saying that they're receiving appropriate treatments. And we see that as a huge barrier in terms of mitigating that bridge for patients who are in recovery and trying to maintain some period of stability in employment. I'm just curious if in your research and in a lot of the advocacy work, if there's anything you would recommend to bridge this really awful gap that are often very much disproportionately impacting functional community?
Yeah, that's such a great question, and thank you for asking it. I think that it's so interesting because I think it's like you focus on a problem that it's interesting in the fact that people are pushing towards treatment and trying to destigmatize the use of these services, but yet until like there's actual regulation and policy behind it, it's very difficult to actually make anything happen. I mean, you could think about just like the legalization of marijuana and how like people are able to in states still be able to engage in such things, but then employers might still have drug testing. And so then it's like, well, state and federal, and it's like kind of a problem, you know, same thing with some states that might be more amenable to having, for example, drug injection sites and things like that, like, which means might be more amenable to certain policies that might lead towards being open to having positive drug screens if they're within treatment and stuff like that. So I would say that it would have to, it's interesting, and it's something that I think there's policy advocates that are pushing for these things to try to make that a reality that wouldn't be, would help the destigmatization of MOUD. Cool,
Thank you very much. Thank you. Thank you. For me, it's just fascinating to watch, as we've heard these different presentations, the interplay of some of these same social drivers and how they show up in so many different ways. Our next presenter is Jason Marvin.
Yes, there's one. Ooh. All right. Well, good afternoon. It's always tough to be right before lunch, so I promise not to keep you bored and to make sure we get to lunch relatively on time. So I'm Jason Marvin. I am a postdoctoral fellow at Mass General Hospital and the HMS Department of Genetics. And I'm going to be kind of taking a step back and sharing more of a snapshot or a highlight of the fundamental basic science work I've been doing as a postdoc here. And the title of my talk is The Role of the Innate Immune Response in Regulating Regeneration of the Adult Zebrafish Thesis. So to kind of give you more context as to what the thesis is, in the Galloway lab at Mass General, we study tendons, which are dense connective tissues that connect muscle to bone. As you can see here on the schematic on the left, when the muscle contracts, it transmits mechanical forces to the tendon in the middle, and that then enables locomotion of the skeleton. This is quite important for joint stability, as you can imagine, for enabling our everyday physical activities. So the adult human body has as many as 4,000 tendons, and they allow us to do things ranging from things you don't think about, like blinking, to maybe things you think a lot about or have to think really intensely about, such as rock climbing or physical activity that's more strenuous in nature. And important to tendon function is I want to show on the left is a micro scale resolution image on a microscope of the tendon structure. So that gray signal you see really helps depict that really beautiful parallel orientation of the collagen fibers on the tendon, which are interspersed with these resident tendon cells or tenocytes. And so the tendon is largely composed of water and collagen, as I mentioned, the protein most abundantly found in your hair, your skin, and bone. And it's really interesting because the tendon has this really unique interfacial site called the enthesis, which is where the tendon inserts into the bone. And shown on the schematic on the right, what I hope you can appreciate, and not so much the nitty-gritty details, is that you have this soft to hard tissue interface. So you have multiple tissues occurring, and this is really where that transmission of loading occurs to allow for the movement of the skeleton. So in terms of the clinical burden, these injuries or tendinopathies account for nearly a third of all musculoskeletal consultations in the US each year. And so as you imagine, as we get older, or when we have disease or undergo repetitive work movements, trauma, et cetera, we're really susceptible to these injuries. And so instead of having this, nice elongated orientation of the tissue and these tendon cells interspersed in between. So really important to the health too is not only the tissue, but also the cells and their health as well. And so in adults, these rarely heal on their own when you get any form of tear or rupture. And what happens is you get this formation of scar tissue that loses that really beautiful organization of both the tissue and the cells. And then thesis in particular is really susceptible to these injuries because of the fact that it has these multi-tissue structure. And I just wanted to point out that in contrast with other musculoskeletal conditions like osteoarthritis, there have been really few studies that have looked at health disparities in both the prevalence or treatment of tendinopathies. And I wanted to point out that originally I thought, why is this the case? Because it's not that we've not been studying this tissue for decades. But if you look at orthopedic surgery, it remains the least diverse medical specialty. And this is true when you also stratify this beyond just race and ethnicity. I think people often think of like the ortho bro, like a straight white man. That unfortunately tends to be the case and is still true for the most part. And so there's really a huge, larger overarching problem that I can't address in my talk today, but I want to kind of showcase that as to a driver as to why we don't know these questions yet. And so when you get these injuries, let's say if you like reach too hard for something in your cupboard, or if you have a nasty fall while playing basketball, we try to have the gold standards be not surgery. So these are things like physical therapy or biologics. Oftentimes patients will get prescribed anti-inflammatory drugs to help mostly with the pain, because this really leads to severe mobility deficits and disability. But in most cases, a lot of patients resort to surgery, especially when you have full rupture of the tendon, because you want to reestablish that mechanical integrity and restore that patient's functionality. But the challenge with this is that it's a very mechanical solution in which you kind of just suture these torn ends together. And problematically, these surgical procedures actually fail as high as 94% in patients 2 years post-op. And so you can really see there's a huge pressing issue clinically that hasn't been addressed despite their prevalence. And a really big hurdle to developing more effective therapeutics is that we really don't know what the biological mechanisms are that underlie regeneration of the tendon as opposed to scar formation. And so in our lab at Mass General, there's a whole spectrum of regenerative animals in nature that we can look to for inspiration, but we focus on the zebrafish. And before I get into any more details, zebrafish have tendons. That's always a question we get is, do they have tendons? They have a skeleton, they have everything that we have organ-wise. And they're really advantageous for studying mechanism because they also share a lot of their genome with that of mammalian species, and their tendons develop and possess similar structures to that of our tendons. And not only that, they also have comparable immune responses, as I alluded to in my title. So kind of diving into this, a lot of the precedent for when I joined my group at Mass General, a previous postdoc, Marie, had actually shown that in the craniofacial tendons of zebrafish, in this case, we refer to the MST. This is a tendon that helps in feeding, but it turns out that when you surgically transect it, it doesn't matter. They're still happy, they still feed, they're fine. Shown on the right is another microscopy image of a tendon without any injury. Again, there's this really nice, what we call SHG signal that gives you an illustration of the collagen tissue signature. Again, you can see that nicely parallel structure. And then this scleraxis A and cherry or red signal you see is actually a transgene that we've genetically engineered the fish so that all the tendon cells are labeled in red. And so we've also developed surgical methods to study injury. And so you can just take a microscalpel blade and cut off the tendon from the bone, and the fish resumes activity as normal. It just goes back to swimming in its tank. And it turns out that after 7 days post-injury, these fish can actually spontaneously reattach their tendons to their bone, which is not something we can do, unfortunately. Oftentimes we need surgery to really get that restoration of structure. And when you continue this healing process after several months post-injury, they fully regain their original tissue structure and function. And so this can be very fascinating because we can study mechanisms of regeneration, but it can be easier if we can also study and compare to instances where they don't regenerate. And so it turns out there's also mutant zebrafish lines that lack certain proteins in their tendons. In this case, tenacin C, which is a glycoprotein that's found in tendon and in thesis. It's known to play a lot of pro-inflammatory roles in other mechanically dynamic tissues like the heart. But surprisingly, nobody has really studied this in the context of tendon regeneration. And so we've discovered that when these zebrafish that are mutants lacking tenacin C protein, they actually undergo impaired healing of the enthesis, wherein at 7 days post-injury, there's this gap indicated by these 2 yellow arrows, indicating that the tendon has no longer able to reattach to the bone, and this actually persists out to long-term healing outcomes. So clearly there's an issue with how these fish are able to regenerate. And so because of the fact that tenacin C has very clear inflammatory roles in other tissues, we thought is impaired enthesis healing in these tenacin C zebrafish mutants due to an altered immune response. And so the objective of the study, and just kind of the highlights of what I'll share today, is our main objective was to determine how do different innate immune cells and their associated mediators contribute to enthesis regeneration. And we hypothesized that the tenacin deficiency attenuates pro-inflammatory activity required for regeneration. And so luckily, when I joined the lab, we really needed to have questions as to where was a starting point for this, right? So work by Murray and Stephanie in our group had actually taken samples from these regenerative wild type fish, in other words, no genetically engineered fish, they're just normal zebrafish, and the tenacin C mutants. And we harvested tissue from uninjured samples, as well as 7 days post-injury to get a snapshot of what's occurring, both without any injury and throughout that healing process. And we can collect these samples for RNA sequencing, which basically gives you a snapshot of all the genes at any given point to see what's occurring in the tissue. And not to really get into the nitty-gritty of the details of the data on the right, but what I hope you can appreciate is that on the left column are comparing these wild type zebrafish with tenacin C mutants with uninjured samples, and on the right is showing the injured samples. And across the board, you basically see in both columns, it's always either blue together or orange together. And the boxes in blue indicate processes that are actually enriched in wild type zebrafish. And it turns out when you look at it, anything to do with the innate immune response, like the movement of these immune cells or their activity and what they secrete, they're all enriched in the wild type. So this really suggests to us that this computational data indicates a dampened immune response in the tenacin C mutants. But of course, to experimentally validate these computational findings, we needed to see whether or not this was true. And so we know from the literature and our past studies that in the context of tendon regeneration with these acute injuries, the inflammatory phase where a lot of immune cells come in and try to help initiate that reparative process occurs within the first 3 days of injury. And so to do this experiment, we have genetically engineered fish in the lab that can actually label both tendon cells, as I mentioned earlier, as well as immune cells in different fluorescent proteins. So the tendon cells in red and different immune cells will be shown in green. And so what I'm showing you here are just the regenerative zebrafish with different time courses of injury on top. The white dotted lines show you where the injury site is, so it labels where the tendon is. And then any green dots you see are immune cells that have actually infiltrated into the injury site. And so what I hope you can appreciate is that without any injury, you don't really have a noticeable immune response, which is normal because the tissue is nice and healthy. And as you start progressing through injury, you have this influx as early as half a day post-injury that peaks at 1 day, and that actually begins to resolve within 3 days. But when you look at the tenacin C mutants with injury, there's a complete lack of immune cell infiltrate throughout all time points that we measured. And I'm just showing the first 3 days. We've done it at the 7 days post-injury. There's just this clear absence of macrophages in particular, which are very key players in the immune response. And so this was interesting because this really does suggest that the tenacin C mutants harbor this dampened immune response that may underlie their poor healing capacity. And so zebrafish are a really cool model system to study for biology because we can do things like swim them in drugs to test the role of different signaling pathways and how they manifest and contribute to different processes. So in this case, thinking back to the clinical connection, we know that a lot of patients will take NSAIDs to really help with the pain relief, and that these NSAIDs actually have shown negative outcomes for healing in patients. And so when we look at what NSAIDs are targeting, they target these enzymes called COX-1 and 2 that catalyze the production of an inflammatory mediator called PGE2. And PGE2 then binds downstream of its receptors EPs 1 through 4. And so without getting too much into the nuances of the signaling pathway, what I want you to take away is that we can actually swim the fish in drugs that target these enzyme activity, or more selectively specific pathways of inflammation, as well as more downstream this receptor binding activity to get at different levels of inflammation in this pathway. And we can swim the fish over the course of 2 weeks and then collect them after injury to see how this affects regeneration. And so on the left is showing you a control fish where they've just been swam in a vehicle control. And what I hope you can appreciate is that the SHG and cyan, which is showing that collagen structure, you have that reattachment of the tendon to the bone, which is demarcated by the yellow dotted line. And then when you look at these injury margins for fish that are swam in NSAIDs or inflammatory drug inhibitors, they actually have this increased gap margin wherein the tendon no longer is reattaching to the bone, indicative of worsened healing outcomes. And as engineers, we love to quantify things, so we like to measure how big is that gap size. And so it turns out that when you swim fish, and specifically the receptor antagonist group, we have a significant increase in that gap size, indicating a larger injury defect. And this is actually inversely correlated with the intensity of how strong this collagen signal is. And this is dramatically reduced with injury in that same group. And I'm not showing the data here, but we do more selective inhibition of COX-2 alone because NSAIDs in themselves are very broad acting. We actually see much more potent effects on this aggregation and regeneration. So this leads us to a few final questions in the study, which were, what are the actual effects of these drugs on the immune cell cascade? Because I'm showing you now that if we lose the innate immune response early on, we don't regenerate these tendons, but what are they doing to the immune cells? And so repeating the earlier studies where we collected the samples for this immune cell cascade, I'm showing you here the same drug conditions, this one on the right just being the more selective inhibitor. On the top is showing you half a day post-injury, on the bottom is 1 day post-injury. And what I just want you to take away is that compared to the controls on the left, where you see a lot of green cells infiltrating into the wound site marked by the white dotted lines, we have noticeably absent infiltration into these drug-treated conditions on the right. And so what this tells us is that we're actually capturing key features of the tensin C mutant by administering these drugs that target inflammation in these fish. And so the last thing I want to leave you on is because we see that there is this dramatic reduction in a key cell population called neutrophils, we thought, what if we use genetic strategies to just kill off all the neutrophils in the fish before injury? And so it turns out if you just swim the fish in this particular drug, it catalyzes a reaction that actually induces cell death. And so we can actually kill off about 90% of the neutrophils prior to injury. And then when we collect the samples of that same 7-day post-injury indicative of reattachment, we once again see that these drug-treated fish that lose their neutrophils don't reattach the tendons to the bone. And this is indicative, again, of worsened healing outcomes. And so this tells us that neutrophils are indispensable for regeneration of the enthesis. And so just to summarize, what the work has shown is that we have now discovered that PGE2 signaling and infiltrating immune cells play a very pivotal role in facilitating enthesis regeneration in adult zebrafish following acute rupture. And ongoing work is doing kind of these opposite experiments where we're now giving these fish PGE2 to restore healing, or that's the hope at least, to see whether or not this actually results in a gain of function. And kind of thinking more to the future in terms of how this will translate to the clinic, we're really hoping that beyond just giving, fish and hopefully larger animals PGE2 modulation therapies, we want to really help define these optimal therapeutic windows in which perhaps where we know that people are always going to take NSAID because that pain is insufferable. But can we help patients and clinicians maybe better guide patients as to when it's best to take them so that we can actually augment the healing response or at least avoid when it's most necessary for inflammation? And so this is quite important because I think there's a lot of disparities in just how clinicians approach post-surgical management. Some people advise like NSAID 6 weeks after injury, some do it right after. So there's a very huge window. I just told you in these species, the inflammatory phase is the first 3 days. So really there's not a clear picture of where we should start with, and we're hoping this project can help make more benchmarks for the future. And with that, just to acknowledge my funding sources, my lab, and also my mentors, Jenna Galloway and Cliff Taven. Happy to take any questions.
We have time for one question, and as you did this, I didn't know this was going to be so relevant. So both of my shoulders are completely taped because the capsules are ruptured on both sides. I'm like, I wish I knew about this a long time ago. But for me, very, very much relevant. Question. Question about the inflammatory response and stress. So if there's more research around stress and the inflammatory response, and your findings, it'd be really interesting to see if some of this can be applied in terms of when do you dampen or how do you address the inflammatory response related to stress and how that'll impact, I don't know, regeneration, health, et cetera. I just would love your thoughts on that.
Yeah, no, that's a really great point. I think there's a lot of things to be considered, especially related to stress as well, that affect the immune response, like metabolic syndromes, diabetes, for example, autoimmune disorders. These are all ongoing areas of investigation that I think we're just now kind of reaching in the field. And unfortunately, in a lot of these situations, those patients, at least from what I've seen, have worsened healing outcomes, both in preclinical models and also in patients. And so to your point, I think we're really trying to understand, are there ways that we can maybe non-invasively learn what the basal immune response state is? So that way, if we're going to give a patient this intervention, whether it be NSAIDs or give them physical therapy because exercise has been shown to also boost the immune response in certain aspects. I think these are all like kind of key questions we're trying to hold on to for the future.
Thank you very much. And now I'd like to invite to the podium, Dr. Lori Zephyrin, who is Senior Vice President for Advancing Health Equity at the Commonwealth Fund. Dr. Zephyrin.
One second.
Wow, this is great. What an amazing morning. Makes me want to go back to research and training. I've learned about zebrafish and more applications of SDOH and the neuroregenerative stuff. I mean, it's just, I think, fascinating, and I can see the intersections on equity, because whether we're talking about technology or stress, there are populations that are more impacted that may not necessarily receive some of the advancements or treatments. And also we have to think about policies to ensure that it's equitable as well. So thank you for all your presentations. I'm jazzed right now. So I know I'm the thing that's keeping you between me and lunch, so I'm going to be on time. What I want to do is just talk through a little bit of what we're doing at the Commonwealth Fund, and I think there's a lot of synergies with the work that's happening, because everything that you're doing, it just shows the importance of policy and systems change. And so I thought we're talking a little bit about how we're thinking about it. I would also love your thoughts after. I guess I should figure out how to use this thing. You would think I would know by now. Okay, you know what? I'm just gonna do the keyboard. Okay, that doesn't work. What do I do? I don't know. Oh, wow, look at that. Okay. So for the Advancing Health Equity work at the Commonwealth Fund, we have a program at the Commonwealth Fund that's focused on advancing health equity, and all of our programs at the fund are thinking about equity in a meaningful way as well, to just ensure that our work is applicable to all populations across the US and more broadly. So our goal is to eliminate unequal treatment, experience, and outcomes for people of color by addressing systemic racism in policy and practice. And so the thought is, by driving policy change and systems change, that can trickle down to advancing health equity. And for your talks today, you really talked about some of the policy implications, which is really critical. I think those policy implications, to be able to advance policies, it's also thinking about how do you get the eyes and ears of policymakers, whether it's local or health system wise or federal, to help advance some of those policies as well. And so part of our work at the fund is to try to support research into current policy opportunities, or engage with public and private payers. I know that there's some payers in the room, government stakeholders, or really get a sense of how CMS or Institute of Medicaid Innovation or HRSA or CDC are really thinking about federal policy, and how we can use our work to help inform that policy making. And policymakers are busy on the policy. I've been on the policy side. You're ripping and running. So to be able to have like concise information that you can look at that's relevant is really valuable. And I've just been so surprised that just sometimes policies are made on studies that have like 5 people, at the state level. And so it's really important to be able to think about the work that you're doing, how to craft that message, and who's your audience. And ultimately, as we think about our work to bring together sort of multidisciplinary stakeholders together, hopefully our goal is to be able to drive implementation and development of policies that advance health equity. And sometimes that takes time. And sometimes, I've been really surprised at just hearing from local advocates in Florida who are like, we took your research to our local congressperson and got this, law approved. I mean, so it's just really fascinating how the importance of your work can really drive change. And we also think about healthcare systems too. And, I've thought a lot about top down, how do we drive policies that can hopefully influence systems, that'll influence providers. And now I'm also at the point of, a lot of this change happens on the ground. It happens for the day-to-day people doing the work. And so I do think it's important to think about how can you drive community-led innovation? How can we drive resources to people that are actually doing the work on the ground so that, because they know their communities and they know what's needed as well. And so part of our work is also thinking about that as well. What are interesting and opportunities for public and private funding? Are there opportunities for philanthropy to contribute and the private sector to contribute to really help drive some of that bottom-up innovation? And while we're thinking about that, also, we're focusing in on some of the equity measures and looking at best practices and showcasing interventions. And so in some of the work that you've presented today, you've highlighted some best practices and interventions. And so I'd say definitely continue that work because that's the type of information that we need. If you go to our Commonwealth Fund website, these are some of our publications and some of our recent work around the State Health Disparities Report that came out within the last month. And I'll talk a little bit about that work, or really looking at the role of midwifery care in terms of the maternal health crisis, or even looking at healthcare providers and talking to healthcare providers about their observations of discrimination. And for each of these areas of work, it's been really fascinating how local policymakers and federal policymakers and their interest in the work in terms of like, how can this inform our policy? What do we write? Who do we talk to? And sometimes I reach out to many of you and like, talk to such and such. They're on the ground and they know this work really well. And so as we think of in the Commonwealth Fund, in terms of our work, we want to be able to identify new ways to inform policies, inform equity within policies as well. So whether we're translating data to support development of equity-centered policy, whether we're understanding healthcare workers and perceptions of racism, or whether we're facilitating the development of equity-focused research agendas. And we don't do all of this ourselves. We do that in partnership with those of you that are doing research, or those of you that are leading systems, or those of you that are on the ground helping drive policy change. So this is some work that recently came out. It's on our website at the Commonwealth Fund. It's our Commonwealth Fund 2024 State Health Disparities Report, which, to no surprise to any of you in the room, no state has achieved health equity. But when what's interesting is states, whether it's media or local policymakers, they want to know how their states are doing in comparison to other states. They want to know, okay, what are the things that we need to do in Massachusetts, in New York, in Idaho, in Georgia or in Tennessee to be able to advance health policy. And so, so what was really interesting to me is when we released this report, I mean, we had over 100 sort of news outlets interested, even local policymakers wanting to learn more about not only the data, but how the data tracks to their local policies. So for those of you that are doing work within your states, we have detailed reports on each state, and it helps. It doesn't provide all the answers, but it can at least provide some questions that you can ask in terms of helping to drive policy change locally. We recently also partnered with African American Research Collaborative to conduct a qualitative and quantitative research to understand discrimination against patients. So in practicing, within the healthcare system, I always, wondered how as healthcare workers, we react to discrimination when we're witnessing it, or was it just me? And so we actually had the opportunity to survey about 3,000 healthcare workers across the country to ask them their views of racism. Do they see racism? How does it impact them? And about half of all healthcare workers say racism against patients is a major problem or crisis. This work is actually available online, healthcareworkerpoll.com. And one of the fantastic things about working with the African American Research Collaborative, and we've worked with them previously on a national poll around COVID, is that the data is available to everyone. It's on the website. We partnered with communities. It is a representative poll. And I think it's really important because people are still surprised that healthcare workers are actually witnessing it, whether you're the technician or the person at the front desk or the physician or the nurse, you see racism happening in front of you or discrimination, and it impacts you. And so it's really important to be able to put this work out there and also contribute to the work around policy change in the space. We also have work around looking at costs of maternal morbidity. We're actually going to be coming out with some societal costs around some of the abortion policies nationally as well. And so we'll be coming out with that work in the next few months as well. And so as we're doing this work, it's really to help inform the development of equity-focused research that informs policy. And so this is really something that's, I think, critically important today, because as we see the impact of policy really affecting equity, even I think more so now. And so we really need to have the data out there. We need to have the research to really show the equity impacts of policies, who's being affected and what needs to change. So I just wanted to just show you some of the work that we're doing. The team that I work with at the Commonwealth Fund, who's amazing. Some of you have talked with some of them, but all the work that you're doing, it's really critical, and continue to think beyond the work in terms of how it informs policy, how it informs systems change, because it's really critical. And so today was just really inspiring. Congratulations to all your projects. I've been in your shoes, so I know it's not easy. And so thank you, and really excited to watch your work and continue into the future. Thank you, Dr.
Thank you very much. And I just want to say congratulations to all the presenters this morning. Excellent work, important work, impactful work. And look forward to hearing, seeing, learning more from this and watching you continue to grow in your fields and in your professions. So can we have a round of applause for all of you?